Endotracheal Intubation. Patient Assessment. To begin, assess the patient with the help of a mnemonic lemon. Look externally for signs of difficult intubation such as those with large tongue, short neck, obesity, dentures, and large incisors. Evaluate 3-3-2 rule, which is an assessment tool used to predict difficult intubations. 3 finger breaths for the mouth opening, 3 finger breaths for the hyoid mental distance, and 2 finger breaths for the thyromental distance. Third, we assess the Malampari score. Ask the patient to stick out his tongue and assess the oral cavity. The higher the grade, the more difficult is the intubation. Next, we assess for any signs of obstruction such as tumor abscess, foreign bodies, and expanding hematoma. Then, neck mobility is also checked. Preparation of materials. Remember the mnemonics MAIDs. M for monitors, which includes cardiac monitors and pulse oximeter. A for airway equipment such as laryngoscope, stethoscope, endotracheal tubes, and bug valve mask resuscitator. I for intravenous fluids. D for drugs, which includes neuromuscular blockers, anesthesia, and sedatives. S for suction, including suction machine and catheter. After preparing for the materials, check the patency of the tube by inflating it and then deflating it right after. Positioning of the patient. Position the patient in a sniffing position by placing a pillow or a towel under the patient's head. A combination of neck flexion and head extension is considered suitable for endotracheal intubation. Basic airway. Suction secretions that may cause airway obstruction. Then perform the jaw thrust maneuver by moving the tongue anteriorly with the mandible, minimizing the tongue's ability to obstruct the airway. To maintain the airway, an oropharyngeal airway can be inserted through the mouth or a nasopharyngeal airway through the nose. A few minutes of pre-oxygenation is started prior to intubation whenever possible. Hold the mask with good grip to ensure an airtight seal. A laryngeal mask airway is an acceptable alternative to mask anesthesia in the operating room, used when endotracheal intubation is not necessary. Advanced airway. The laryngoscope is held in the left hand and is inserted along the right side of the tongue, pushing the tongue to the left. Traction is then applied along the long axis of the handle to visualize the glottis opening. The endotracheal tube is then passed at the right corner of the mouth. The tip of the tube is passed through the glottis opening and is advanced by 2 cm until properly placed. Carefully remove the laryngoscope. Inflate the cuff using the 10 cc syringe. Remove the stylet carefully while holding the endotracheal tube. Attach the tube to a bug valve mask resuscitator for oxygen. Anchoring of the ET tube by using tape. Then evaluating the placement of the tube by auscultating the chest as well as the epigastrium. Equal breath sounds must be heard over both lung fields.